Awesome. Here we go. Welcome, everybody, to this legislative briefing brought to you by the Hypertrophic Cardiomyopathy Association. I'm Lisa Salberg. I'm the founder and CEO of the HCMA, and we have been doing this work here since 1996. We serve approximately 25,000 families living with HCM worldwide, and it is our goal to educate you, state legislators and staffers, on what your state can do to help prepare for sudden cardiac arrest and identify those with genetic heart muscle disorders to get to them in time. We're going to be hearing from the panelists that you see in front of you right now, Dr. Melinda Tsai from the Cleveland Clinic, Noah, who is coming to us from Model Solutions, Amy Blair, who is a mother and patient with hypertrophic cardiomyopathy, and Julie Russo, our legislative lead. So if you have any questions at the conclusion of this webinar and you have any questions you want to talk to us about specifically, please set an appointment with Julie Russo, and she will help you walk through everything, and Noah can jump online with those meetings as well. Without further ado, let me share my screen and get down to business because we know you're all really busy and we respect your time. So today we're going to be doing a Minnesota legislative briefing. So hello to all of our friends in Minnesota. I'm going to go over some base information about who we are, our state report cards, and how you can improve your grade. And I've already introduced our panelists, so I did that a little out of order. Then we're going to be hearing from Dr. Melinda Tsai, and we're going to hear about what is HCM and other thick heart muscle disorders, why are we looking for these diseases in children, and how we can improve family screenings. Then we'll talk a little bit about the legislative language. We'll hear a personal story, and then Noah will tell us what action we need to take in the state of Minnesota. So who are we as an organization? We're a 501c3 nonprofit, again, founded in 1996. And it is our job to provide information, support, and advocacy to all those with thick heart muscle disorders and genetic heart disease. We are doing this through our staff here in New Jersey and our remote workers in Wisconsin, Pennsylvania, and Texas, and California. And we are also working internationally to build HCM awareness throughout the globe, including Latin America, India, Australia, and Europe. And Minnesota, let's talk about the United States and Minnesota right now. So the HCMA has created a report card, and that report card looks at a number of different features. And a big thank you to the state of Minnesota for recognizing HCM Awareness Day as the fourth Wednesday of February. And we just got that proclamation in a little while ago, and we'll talk about that in the next slide. We do have some AED laws in the state of Minnesota, but there could be more done in that space, which is covered in the Children's Cardiac Safety Act. And congratulations on great CPR training and Good Samaritan coverage in the state. There are some other things that we can work together on to improve coverage for medications for those with HCM and other genetic diseases, but we're going to talk about that on another day. So these are our proclamations and recognitions over the past 3 years since we really started this initiative. Right before we got on the line here, we found out that Delaware and Washington, D.C. have proclamations as well. So you'll notice that Minnesota is right up here, and they came in the order in which we received the proclamations this year. So thanks for getting in there nice and early, Minnesota. Why is it important to have an awareness day? It gives us an opportunity to talk about a particular disease state or a problem and really focus on solutions to address the problems for that community. And that's what we're doing here today, is helping you understand what the needs of this particular community are. And now I'm going to hand it over to my dear friend and colleague over at the Cleveland Clinic, Dr. Melinda Tsai, who has some really interesting information he's going to share with you. And he's currently down in Texas doing some work on behalf of the community right now. So thanks, Dr. Desai. And I hand over the microphone to you.
Thank you very much, Lisa. And I would like to sincerely thank the legislators for giving us this opportunity on behalf of HCMA. What is hypertrophic cardiomyopathy? This is a disease of heart muscles. For my patients, I like to simplify it as follows. It is hypertrophy means thickening, cardio means heart, myo, muscle, pathy, disease. So it is a disease that results in undue thickening of the heart muscle, which cannot be explained by other situations. This makes the heart become a lot stiffer and leaves less room for blood to fill the heart. This is pretty darn common. It is the most inherited cardiovascular disorder with the range between 1 in 250 to 1 in 500. We are recognizing that the prevalence is even more than what we thought in the past. If we do simple math, that makes it about 1.3 million patients in United States who may have HCM. However, unfortunately, we know of only 150,000 patients, which means about 80 to 85% patients are either undiagnosed, misdiagnosed, or certainly underdiagnosed. And a big problem here, if not well managed, there is a slight higher risk of sudden cardiac death. And HCM is the most common cause of sudden death in young folks. It can also cause symptoms of heart failure or stroke at any age. While HCM is the most common, there's a lot more other genetic or congenital heart diseases. Next slide, Lisa.
Yep.
So, I do not want to have a very complicated table, but we'll start with the bottom row. Total population with cardiac diseases, with inherited cardiac diseases in the state of Minnesota. High end could be as high as 182,000 folks. Low end is almost 62,000 folks. And the most common being HCM. There are other diseases that are inherited. We don't need to get into the details of it, but some of it where the right side of the heart is affected, some of it where the heart muscle gets very big. In some, you may have electrical problems, some where your aorta is big and can result in an aneurysm, some where there's anomalies in the way your coronary arteries come out of the heart. So this is a potpourri of inherited diseases, and we need to continue to do our part to increase awareness and improve diagnosis. Next. What are some of the symptoms and signs for hypertrophic cardiomyopathy, as well as some of the other genetic diseases? Obviously, a family history is often the first clue that something is going on. Occasionally, the doctor may hear heart murmur, which triggers downstream investigation, which then makes the diagnosis. Often, the interesting part or the confusing part is that the symptoms can be similar to a lot of other diseases as we have listed here. You could be short of breath, palpitations, chest pain, fatigue, lightheadedness, may pass out, or you may have no symptoms. So we are trying to basically unpeel the onion here when somebody presents with these broad spectrum of symptoms. The problem is the potential complications. The worst case scenario is an unexpected and sudden cardiac arrest. As we all know, even in the best scenarios, the success rate for a revival in the field from a cardiac arrest is no more than 10%, maybe a little better now, but it is dismal. You may have arrhythmias, including need for a pacemaker. There may be symptoms that may not kill you, but may have significant impact on your quality of life. Endocarditis is where there's infection of the heart valves. You may just not you may do okay for a while, but then you continuously progress with heart failure to a point where the heart just gives up and you end up needing a heart transplant. So bottom line is it is not a we need to get ahead of it before bad stuff happens. And prevention is better than cure in many ways than one. Why is the early diagnosis important? As I alluded to, if you are at a higher risk for sudden cardiac death, we can put a defibrillator as a life insurance policy to shock you out of a bad rhythm and save your life. If you were to develop progressive heart failure symptoms, there are new emerging treatment options that we can prescribe you that may slow or halt the progression of disease. In some cases, surgery or transplant may be needed. Atrial fibrillation is an irregular heart rhythm that exponentially increases your risk of a stroke. And if we diagnose it, we can treat it. We can effectively cure it. For sure, we can utilize strategies like using blood thinners to significantly reduce the risk of a stroke. More importantly, if we know what is wrong with the patient, we may screen other family members, what we call cascade screening. So, as I alluded to, this is a genetic disease, and like many other genetic diseases, it occurs due to mutations in various part of at a cellular or a muscle level, and there are the buzzword nowadays is this polygenic, meaning it may not be one mutation, there may be more than one mutation factors triggering severity of disease. Typically, this is familial. HCM specifically is what we call an autosomal dominant inherited disease, which means disease occurs in 50% of relatives in each consecutive generation. And if there's an affected parent, they can transmit an abnormal gene to a child in about 50% cases. Just because you transmit the genetic mutation doesn't mean you're going to develop severe disease, but it is important to know so that we can continue to progressively monitor. I'll stop here and thank you for the opportunity. Lisa.
Thank you, Melinda. So the Children's Cardiac Safety Act is a draft legislation that you can get using this QR code. And what we are doing isn't anything crazy. We're not looking to do a particular test on every individual patient. What we're doing is we're asking a set of questions that have been vetted for many, many years through the American Heart Association, American College of Cardiology, and others to evaluate those who are at high risk for cardiac conditions in the young. We do this typically in competitive athletes. We want to expand this to all well child examinations, as it is the only opportunity a parent has to talk to a healthcare provider about the overall health of their child. And if there is a genetic risk in the family, we want them to be able to have a conversation with their chosen healthcare provider to identify the proper path forward. For some diseases, it may be as simple as an EKG. For others, it may be an EKG and an echo. For others, it may include an MRI or other cardiac testing, including CT scans. So we don't want to say this is the test that somebody needs. We want to facilitate a conversation that is based on fact and education. We also want to create professional development tools so healthcare providers become aware of what diseases should they be looking for, and what are the triggers, and what is the proper referral pattern for that individual pediatrician or family practice doc. We want to improve the student athlete pre-participation physical and improve education to families and coaches about signs and symptoms that are likely tied to cardiac conditions, so that they not only can have response plans created and practice those response plans, but also know when to refer that individual athlete or child back to their doctor for an evaluation. We hope to improve the ability of healthcare providers to identify families who are at risk of genetic diseases and understanding how potentially to use that information to help other family members. And we want to improve AED coverage and training throughout your state. So, what do we know about this type of a law? We've had it here in New Jersey since 2015. I'm from New Jersey. And of course, you start at home. And we know that it is bipartisan in nature, as everyone has a heart, no matter your political affiliation. We are not asking to do a test or change the process of healthcare delivery, but only to facilitate conversation. It is proactive as opposed to reactive. It limits more costly diagnostic procedure to those who are screened in this process. And in the event somebody might be adopted, we may go a different path versus somebody who has no known family history and a very long family history that they can articulate versus somebody who has some questions. So let the doctor and the family make the decision as what's right for them. We know it is much more cost effective to treat somebody ahead of a cardiac arrest than after, as they may develop very serious consequences, including neurologic deficits that can track with them for the rest of their lives. We want to promote overall cardiac health and well-being for all children, not just student athletes. We know it was successful in New Jersey. We have seen an increased diagnosis here in the state of New Jersey, and we have seen a decrease in sudden cardiac arrest and an improvement in community preparedness for cardiac arrest, including better AED laws and better preparedness training. This model language has been vetted through the American Heart Association, which I'll speak on in the next slide. And we do know that these life-saving opportunities provide the ability for healthcare providers to identify not only children, but families who are at risk of cardiac disorders, both genetic and congenital. So we started this work back in about 2020, trying to figure out what we could do as an organization. And while we were doing our work, unbeknownst to us at the time, the American Academy of Pediatrics was much on the same path. And a lot of the names on that article are dear friends of ours. And they came up with the same understanding that we did. We can do more to protect our children's hearts. They didn't have the action plan. We had the action plan. So we are happy that we support the American Academy of Pediatrics and belief that we need to do better at screening our children's hearts. And we are very good friends with the people at the American Heart Association. And our model language has been vetted all the way through their scientific board, and they are in support of the legislation. They're letting us drive it. It's not their top priority, but they do support our initiative. And we can bring in your local heart representatives as needed if that was something that would make everybody comfortable. So now I'm going to turn the microphone over to our dear friend, Amy Blair, who's going to tell us about her beautiful Jillian. Amy?
Hi, guys. It's nice to be talking to everybody. So actually about 3 years ago, almost to the day, I walked into our family physician's office with Jill. She was a junior in high school. She just needed her meningitis shot and a well child check. I thought I'd get a jump start on it. And when our family care physician put her stethoscope on Jill's chest, she looked over at me and she said, "When did Jill get this heart murmur?" And I said, "Jill doesn't have a heart murmur." In the past, my brother had been diagnosed with hypertrophic cardiomyopathy as well as his son. And through the years, I was told different things. Even though I was a nurse, I knew there were certain cardiomyopathies that could be genetically passed down to us. But I was told through his wife and through, secondhand, this is a male to male transfer gene. This is something that maybe came from her side of the family. There were so many different things that I had gotten through the years. I had talked to my family care physician when I was in the early 2000s about my oldest daughter, and they actually checked her over and they had said she was great. I went back, after everything happened and looked through all of their medical records. And for some reason, I was really proactive with her. But then my last two kids came so fast, and I was just a busy mom. Even though I was a nurse, I was a busy mom. I wasn't as attention to the other two girls, and out of all three of my girls, Jill was the one that I worried the least about with her health. We had changed doctors over the years, and so they didn't ask me questions that even like triggered a memory or anything, that maybe I had something lurking still in the genes that was going to get to my kids. And so in February, on that day when, she had said that, Jill had a heart murmur, it led to an MRI and an echocardiogram. And on March 28th, we were told that she had severe hypertrophic cardiomyopathy. We had passed the mild, moderate, we went right to severe. They were talking about doing different things like defibrillators. Were they going to, place an ICD in her? Were they going to do a myectomy? What was going to happen? We went in for genetic testing, both Jill and I did. And on the day, on April 21st, from March 28th, when she was diagnosed, to April 21st, when we got the genetic testing back, she walked in our door. I told her her genetic test had just came back, that she was positive for the MYBPC3 gene. I told her that we were going to be talking on Monday, which was a few days away, about what her next plans of action were going to be. And she was like, "Okay, that's about what I thought." And she ran up the stairs to get ready for her little part-time job. She suffered a sudden cardiac arrest up in her room while she was dressing to get ready for work, and she died on her bedroom floor. And so for me, from all the times, we had a lot of red flags that I didn't piece together, but I also had different doctors who didn't ask me right questions throughout the time frames when I would bring my kids in for their well child checks that would trigger ideas, like, yes, we've had that. Yes, I've had a brother who's had that. I've had a nephew who had a sudden cardiac arrest. He had an ICD that fired and saved his life. In the end, so many people have looked at me and said, like, what happened? What killed Jill? Because from March 28th to April 21st, that was all the time we had. You know, there was nothing that killed Jill except for bad timing and not having earlier detection. Had we had all those questions in, you know, our well child checks in the very beginning, I really do believe that it would have led us to having earlier detection, possibly having, you know, that ICD already inside of her chest, so that when she hit the ground that day, it would have fired and possibly have saved her life. It would have been her best chance. And so you know, I now have HCM, I have the ICD. I am here trying really hard to push that initiative. I don't want this to, you know, continue on happening with other family members and, you know, other people's families. We just want, you know, people to get earlier detection so that we can keep our families intact out there. And she loved Minnesota. We went up to Harry Styles at the concert when she was on her 17th birthday, and it was a blast. So we, you know, we want to have more people who get to have days like that. Thank you.
Thank you, Amy, for sharing your beautiful daughter with us. And again, you know, our hearts break for you. And part of the reason we have this initiative is because of all of the beautiful Jillians that have been lost in the world too soon. And we really think we can get there in time with just some better questions and some action plans. And now we're going to hear from Noah, who's going to teach us a little bit about what we can do in the state of Minnesota to bring this legislation forward. Noah is a contractor with us here at the HCMA. He's currently doing this work as a volunteer. So we thank him for his time and his intelligence. And his company is called Model Solutions because we believe that plugging in the best practices makes sense all over the country. Noah, this floor is yours.
Fantastic. Well, I really appreciate it, Lisa, and Amy. Certainly appreciate your story, and that's why we're here. And so the Children's Cardiac Safety Act has been sponsored by Senator Carla Nelson in the Senate, who has submitted it for drafting. It's not in bill form yet. It's going to be in bill form, and then it will receive a bill number that we can send out to folks for their support. But also, we're asking for folks to support working with their legislators in the House to ask if they could sponsor the legislation on the House side. So following this call, we'll provide the information for you to reach out to both Senator Nelson to express your support and appreciation. She has previously also introduced HCM Awareness Day, so it's just a long-term supporter that we couldn't be more appreciative for all that she's done for us. And then also with the information to contact your House member. Yeah, with that, I'd be happy to answer any questions. It's been our pleasure to work on model policies like this throughout the country for the last 23 years. And so we definitely see this as a model policy best practice that each legislature should pass, and couldn't be more excited about it.
Noah, thank you so much. If you would like to have an individual conversation and you're a member of the state legislature or your staffer, Julie Russo, you can set an appointment with her. She'll walk you through all of the steps that we've taken, what language may already exist in your state. So we have a very comprehensive draft legislation that includes every component. You may already have some of those. We may need to modify it for the state of Minnesota, which is happening right now. But if you have any questions, you want to support, you have some concerns, we're here to help you get through that process. So you can make an appointment with Julie, you can scan here, or you can just call the office at any time. Our contact information is on the bottom of the slide. We will take your questions at this point. I'm going to flip to my thank you slide as we wait for questions to populate. You can use the Q&A box at the bottom. At this point, do I see anything in there? Yes, I do have a Q&A. Oh, Catherine just said, thank you so much for bringing your story. Sorry to hear about your loss. When is the legislative session in Minnesota? Noah, can you speak to that?
Absolutely, it's going on right now. So the sooner that folks can reach out, the better. The legislative session ends on, I believe, May 19th of this year in Minnesota. But there are deadlines that are much sooner for introducing bills and getting those through the process. So the sooner the better in your outreach. But that's they're in session now. Came into session on the 14th of January.
Okay, so we're live now. This is the time to make things happen. This is the time to make calls happen. As I keep the tab open for additional questions, I do just want to take a moment to say thank you to our entire staff, our board of directors, our staffing contractors, our volunteers, our partners, including our Center of Excellence partners like the Cleveland Clinic and the Mayo Clinic, who could not be with us today. So thank you to Melinda Sy from Cleveland for jumping states and coming over here to Minnesota to help us today. We have sponsors, of course, and I am not simply a founder and CEO of an organization, kind of like the Hair Club for Men. I did have HCM, yes, past tense. And 8 years ago this week, I was preparing to leave the hospital with my transplanted heart. HCM came into my family back in the 1900s, early 1900s. We can trace it back. I lost my grandfather, my great aunt, my uncle, my sister, and my father, all to complications of hypertrophic cardiomyopathy. And other family members are currently living with it. And I'm one of the only ones in my family who has survived HCM to the point of transplant. Only 5% of those with HCM will go to transplant, but it's a wonderful opportunity to live a healthier life. My donor's name was Brandy. I bring her up everywhere I go to remind everybody how important organ donation is. So we have a note from Mary here, and she says, will this be an individual effort, i.e. each one of us reach out to Carla or individual representatives in the House and Senate? Question. We do ask that you call, and we will send you a tool through something called UJoin. So you'll get a link soon to that, where you can reach out to your state legislatures and share your story. Our online tool for collaboration also allows you the opportunity to record a short 90-second video. So not only can you write, you can tell them your story in your own words, but you only get 90 seconds. So we encourage you to use that piece as well, Mary. And if you want to get involved more with bringing this bill forward and you want to help be a champion for your state, reach out to Julie and she can give you some talking points and some action items as well. So thank you for joining us, Mary. Okay, I'm going to stop my screen share now. Super, thank you. You're welcome. And that brings us to 28 minutes. Darn, we're getting good at this, covering it in 30 minutes. We know it's a lot of information and it's very heady, and you may not all be thinking about your family heart health history, but here at the HCMA, we want you to know that it's important to talk about your family heart health history, and it's important to talk to your doctor about any signs or symptoms that you may have noticed. Any parting words, Melinda?
I think thank you for continuing to do the work. I think as we have talked, there's a lot of suspected patients walking around with oblivious to what they have. We need to bridge the gap between how many patients we know who have it versus how many patients we think based on prevalence studies. So I think that's the moral of the story here.
I agree. I think there's more to be done. And I think we can save more children and families and keep families whole. That really is our goal here at the HCMA. It's kind of simple. We want families to stay whole as long as possible. And we know it is possible to do that because once we identify somebody, identifying risks and the opportunity for treatment are so great today. We're investigating things up to and including genetic therapies to potentially cure disease in this day. We have defibrillators to protect against sudden death. We have medications to improve cardiac symptoms. There's so much that can be done. We need our legislature to stand behind us and help us get this to the finish line. We're happy to partner with you, and we'll even come on out to the State House and give testimony if that's what you need us to do. So thank you very much for your time and attention today. No further questions. I thank you all for joining. Thank you for watching on Facebook. We're going to leave now, and we are going to close the webinar. Thank you all for your participation. Have a wonderful day. Bye-bye.
Thank you.